We'll start our next session. It's a case snippets based panel discussion. Ignored symptoms in liver disease, cramps, insomnia, fatigues, etc., which will be moderated by Dr. Manoj Sharma. Allow me to introduce our panelists Dr. Pathik Parekh, Dr. Sagnik Biswas, Dr. Vinay Kumar, Dr. Siddharth Harindranath, and Dr. Nitish Patwardhan.
Today we will discuss some of the ignored symptoms in liver diseases. We will try to cover 5 symptoms. And let's see how many symptoms can we cover in the stipulated 20 minutes time. And so first we start with the case erectile dysfunction in CLD. This was a alcohol-related liver disease patient's cirrhosis. He was diagnosed 2 years ago. He is non-bleeder, no history of HE, last alcohol 1 year back. He was on regular follow-up with lacilactone and carvedilol. Now he is complaining of problems having sexual relationship with wife. There is no ascites, conscious, well-oriented. BMI is okay, and there is no ascites or sole, and endoscopy, small esophageal varices. So these are the issues in ED: definition, evaluation, prevalence, associated factors, and management. We will cover every symptom in the same format. So I will move on to our first panelist, Dr. Pathik, regarding what do we understand by erectile dysfunction. Pathik.
So when we talk about sexual dysfunction in cirrhotics, it is mainly either an erectile dysfunction or an ejaculatory dysfunction. When we are talking about ED, it is actually failure to achieve or even maintain an sufficient rigid erection for us sexual intercourse for the patient. It should be ideally persist over a period of time, not a definite answer, but at least for 6 months before to label it as erectile dysfunction in these patients.
Thank you. So erectile dysfunction now we have defined. So how do we evaluate such patients? Dr. Sagnik?
So the evaluation would include both a subjective and objective evaluation. The subjective component of it is the history and physical examination. Ideally, the initial part should be the medical history, which should include all comorbidities like diabetes, hypertension, which are known to impact ED, along with a very detailed sexual history, which has to be again supplemented with an objective evaluation, which I'll discuss later. And also, along with that, the psychosocial assessment like anxiety, depression, which can affect male performance, along with a detailed physical examination to rule out structural causes of ED, along with the other objective evaluation. In the objective system, we have the scoring system, which is the International Index of Ejaculatory Failure. In that, there are again 5 components of the scale. These include sexual desire, erectile performance, orgasmic function, intercourse satisfaction, and overall satisfaction. However, the problem of this scale or its limitation is actually that it only assesses the individual and does not take into account psychosocial background and interpersonal relationship. And a score less than 25 would be diagnostic of ED, which can be graded further.
Yeah. So detailed physical examination, history, and use of questionnaire can be helpful. So next is how common is ED in CLD patients? Dr. Vinay?
Sir, thanks for the opportunity, sir. First of all, the problem is the diagnosis itself is very difficult because the questionnaires are cumbersome and most of the patients won't come up with the symptoms during the clinical follow-up. But most often, any person who has a decompensated cirrhosis have a higher prevalence. In a study where it has shown almost 80 to 90% of patients with a decompensated cirrhosis had erectile dysfunction or symptoms related to it. Also, patients with metabolic associated steatotic liver disease also had a higher number of patients with this erectile dysfunction, which almost was 2.9 times more than the non-NAFLD patients. And among the chronic hepatitis which are related to virus, HCV-related viral disease had more association with erectile dysfunction. If presence of other comorbidities like diabetes or obesity, the problem is much higher.
So ED is quite common and most of the patients are quite shy about this symptom. So you have to maybe sometimes actively ask about these symptoms. So what are the associated factors and mechanisms? Dr. Nitish, please.
Sir, the associated factors are that the underlying comorbid diseases like diabetes, hypertension, they itself they have the effect because of primary vascular causes also. The second associated factor is the mental health of the patient because the depression, anxiety, because of the primary disease as such, also affects and it has an effect on the erectile function. Second is the severity of the liver disease. The more severe the liver disease is, the more amount of erectile dysfunction that has been found. Also, minimal hepatic encephalopathy has been associated with it. There have been various studies regarding the erectile dysfunction because of the primary etiology of the liver disease, though there have been differing results because some studies have found that primary alcohol can have worser erectile function, but there have been differing results. So primary etiology of the liver disease also has an effect on the erectile function of the patient. Then the mechanisms that are associated with the erectile dysfunction are either primarily liver disease related because of the hormonal metabolism, because the testosterone and the estrogen metabolism is altered. So there is increased estradiol and increased prolactin, and that can have an effect. The second thing is the drugs that are commonly used, which are the beta blockers, the non-selective beta blockers, antidepressants, spironolactone. Then there can be insulin resistance, and because of the vascular endothelial dysfunction, the erection function of the patient is affected. And then there are other factors that can play a role, like of the oxidative stress, inflammation, and anemia. Then there has been this study regarding gonadal function in BCS from KEM hospital. It had shown that there was a reversal of gonadal dysfunction after intervention in bud cherry patients. And initially there was about 70% patients were able to provide the semen sample, and after that the 100 the number rose to 100%, and the erectile function improved. Initially, it was about 30%, which then dropped down to 6.2 about 6.2% after intervention.
And also patients have a very poor quality of life in all the health related indices. So this was an actual case who was in a part of a trial on tadalafil use. So we worked up the case, performance score was okay. If you looked at the questionnaire, all the scores are very low. He had anxiety, GAD 7 is an anxiety score, PHQ 9 is a depression score. So more than 10 values of any of these indicates generalized anxiety and severe depression. So he had both. These are the extensive SF36 questionnaire. His functioning was low in all the physical and mental capacities, all the were low. Now we will see what we did. So how do we manage such a case, Dr. Siddharth?
So the basic tenets of management is to identify the root cause of the problem and of course treating the underlying liver disease. It always also helps in identifying what are the risk factors mentioned like alcohol, smoking, substance abuse. What are the medications that are contributing to this problem? Treatment of metabolic syndrome, correction of anemia, correction of concomitant anxiety and depression, a joint psychosexual counseling with the partner and providing psychological support would go a long way. And I would also add a dimension of measuring the free testosterone level in this patient and acting on that depending on what the value is. And in this patient, I would also advise pharmacotherapy in form of phosphodiesterase 5 inhibitor like sildenafil, tadalafil, and a newer agent like avanafil is also available, which has lesser side effects. And certain patients who have structural issues, vascular, neurological, cardiac evaluations would require specialized management.
Thank you. So what we did, he was randomized, this was a randomized control trial, so he was put on tadalafil 10 milligram for 3 months, and then we can see after 3 months, all the IIEF questionnaire scores have increased significantly. His anxiety and depression scores have improved, and his SF36 questionnaires, significant improvement in physical functioning, bodily pain, all the scores, both physical and as well as the mental. So it is important to address such kind of issues also. So we move on to the next. Then this is sleep disorders and cirrhosis. Again, very common symptom. This was a 50-year-old female, 15-year diabetes, uncontrolled sugars, diagnosed cirrhosis 3 years ago, non-bleeder, no history of overt HE, on lacilactone, carvedilol, sitagliptin, metformin, and DAPA. Complaints of sleep problems at night. And again, patient is quite compensated. BMI is okay, and no ascites and no SOL. Bilirubin is almost normal. Albumin is okay. So again, we have the same issues. What do we understand by sleep disorders? First question, Dr. Sagni, please.
So sleep disorders are basically of two kinds. The first kind being a disorder of the quantity, quality, and timing of sleep, which is called a dysomnia. Whereas a parasomnia is more of behavioral or psychological events that occur during the sleep period. So that would be something like a night terror or a nightmare. These are mainly associated with the phase of sleep again, which is NREM or REM. So based on that, the American Academy of Sleep Medicine actually divides sleep disorders into an insomnia, which can be again short or long term. But the definition makes it very distinct that it is a sleep disturbance associated with daytime symptoms which occurs in absence of other sleep disorders. So if we have a patient of OSA who is having increased daytime sleepiness, it cannot be attributed to insomnia alone. This would be clearly an OSA related disorder which would be classified as sleep related bleeding disorders. Again, there are other subclassifications as well, like central disorders of hypersomnolence, sleep related hypoventilation disorders, circadian rhythm disorders again with timing of sleep, so these come under dysomnias, and parasomnias are again sleep related movement disorders which occur during the REM where there is increased movement, behavioral actions, or in the NREM where the patient has something like a night terror and then wakes up not remembering the episode.
Okay. So how do we evaluate such a case, Dr. Vinay?
Sir, as any patient we approach, we try to evaluate the medical history properly, taking the history about the medication, the type of sleep-related problem which they are facing, whether they are having difficulty in getting into sleep, or they have frequent getting up out of the sleep, or they have issues related to night terrors or some other issues. And also one needs to be carefully evaluating the symptoms related to other diseases which may have a role in sleep disorders like hypertension, obesity, OSA, also associated symptoms like restless leg syndrome or pruritus, which might be affecting the quality of sleep. So for evaluation purpose, these patients after a thorough history, one can undergo a gold standard, that is polysomnography. But if it is difficult, maintaining a sleep log or a sleep diary by the patient regularly to think about the sleep hygiene and also the environment which they are in, as well as trying to question them using specific questionnaires like Pittsburgh Sleep Quality Index or Epworth Sleepiness Score. This can be helpful to assess or evaluate these kind of patients with sleeping disorders.
So what the prevalence? How common is this, Dr. Siddharth?
Yeah, so overall it is quite common. Overall sleep disorders are present in almost a tune of 80% of patients. And the severity in the percentage varies between increasing CTP status. CTP-A is around 17%, CTP-B is 30%, CTP-C is the tune of 60%. And excessive daytime sleepiness is present to the tune of 52% of patients. And insomnia is present in around 40 to 50% of patients. And a fair number of patients, around 55%, also suffer from restless leg syndrome.
Okay. So what are the associated factors, mechanisms, Nitish?
So the associated factors are, there can be, most important, there is this restless leg syndrome and muscle cramps, and then sarcopenia, depression, and anxiety. All these can contribute to the sleep disturbances. And the basic mechanisms that are involved in sleep dysfunction is either in the onset and offset of sleep, that is the circadian rhythm, or the homeostatic mechanism of maintenance of sleep. So there should be in the polysomnography report, normally there should be about 3 to 5 REM sleep cycles. Then the REM sleep and the depth is already affected because they have the melatonin metabolism problems, and there is the levels of melatonin in blood are high, and there is a basic disturbance in this sleep architecture. So homeostatic mechanisms are also blunted, and then the thing is the preoptic and suprachiasmatic nuclei, those are affected. There is increased adrenaline and serotonin in the cortical neurons due to ammonemia, hyperammonemia. All these have an effect causing disturbed sleep and early awakenings.
And also very poor quality of life associated with sleep disorders in such patients. So this is our patient reported difficulty in falling asleep. He had restless leg also at night, and there was no daytime sleepiness. Again, this was an actual case, so there was an extensive study done on him because he was also a part of the trial. So he had no M.I.C.E, he has sleep disorder, obviously. Sleep efficiency was very low. It means that patient was going to bed but sleeping only 44% of the time. And sleep architecture was also disturbed. He was spending most of the time on stage 1. He has no OSA, no anxiety, and no depression. So how do we manage, Dr. Pathik?
This patient has a associated restless leg syndrome. So which is the most common associated factors are actually treatment of the reasons why the patient is not able to sleep, and underlying dose optimization for lactulose and rifaximin for hepatic encephalopathy if the patient is complaining of excessive daytime sleepiness is necessary. Other than that, pruritus, restless leg and muscle cramps are very common. So we need to tackle those and optimize the sleep hygiene. So early morning we can have them a routine development of exercise and having a bright light in the morning and trying to have a fixed bedtime routines is necessary. Avoiding, I think the most common reason most of the patients stay awake is they keep on playing with the mobiles late at the night. So having a good night hygiene is important. And if the patient still persists of having an insomnia or falling asleep, short agent of zolpidem 5 milligrams can be attempted along in these patients. Although the other agents tried are antihistaminics, hydroxyzine, whose side effect is sleepiness, so that can be used. Melatonin cycle, I think the problem in this patient is the melatonin cycle is hampered, so melatonin can be attempted in these patients. I don't know whether orexin antagonists are available in the country, but they are the newer set of agents FDA approved which can be considered in these patients as well.
Okay, so very little data on pharmacotherapy, and very carefully we have to use in especially child C patients. So this patient was part of the trial and started on zolpidem 5 mg for 4 weeks. So as we can see, there is no worsening of MHE. Sleep quality has improved, and overall sleep quality is also improved. Sleep efficiency has increased to 79%. And as we can see, his sleep architecture has also improved. He is spending more time in REM and stage 3 and 4 sleeps, and no worsening of OSA or any other symptoms. But we have to be very careful in female patients, old age patients, and child C or high child B patient in using zolpidem. Otherwise, we can use melatonin 3 or 10 milligram. Now, possibly we have time for one more case only. So this is a case of fatigue in CLD, 57 female, diabetes 15 years, MAFLD cirrhosis on sitagliptin, metformin, carvedilol. Now complaints of fatigue and tiredness since then. BMI is slightly obese and hemoglobin is okay, thyroid functions are okay, B12, D3 is okay, ultrasound, no ascites and no sole, endoscopy, small esophageal varices. Dr. Siddharth, what do we understand by fatigue in
Pathological fatigue is the overwhelming sense of tiredness that hampers the daily activities of the patient, but that is not adequately relieved by sleep or rest. So the pathophysiology is not very established, but it involves disturbed neurohormonal regulation in the brain as well as in the liver.
Okay, so how do we evaluate a patient who is complaining of fatigue? Nitish?
Sir, we can, for the diagnosis of pathological fatigue, there have to be at least 5 ancillary symptoms that must be present along with the associated tiredness, such as limb heaviness, inattention, lack of concentration, motivation, etc. So in evaluation, the fatigue can be either peripheral fatigue or a central fatigue. So for peripheral fatigue, there are some simple tests that can be done to assess the muscle function, that is hand grip strength and a short performance battery test, a cardiopulmonary exercise testing. And for central fatigue, we have different scales, that is a fatigue severity scale, and there is a visual analog scale which are most commonly used. So based on this, we can diagnose.
Okay. So assessment requires whether it is peripheral or central, and then proceed accordingly. So let's see what is the prevalence, Dr. Pathik.
All the patients, practically all the patients do complain of fatigue to a certain level, but the literature says about 50% in more on all cirrhotics. But for an autoimmune liver disease, the percentage goes up to 4/5 of the all patients do complain of fatigue in this.
Yes. So again, associated factors and what could be the possible mechanisms, Dr. Vinay.
Sir, most of the earlier symptoms are often associated with fatigue, especially patients having anxiety or depression, or patients with poor sleep quality always have some daytime sleepiness or fatigueness while doing work. And also the causes. Sometimes PBC has a higher cause of fatigue among the patients. And also the viral causes like HCV also has important role in causing fatigue in this kind of patient. And also the treatment of HCV infection has shown betterment of fatigue in some patients, especially after 2 weeks of treatment. So all these factors are associated with the fatigue. Second, the mechanism is not thoroughly investigated. It needs more study. Usually the liver inflammation and the cytokines which are released often have a role in the brain as well as the neuromuscular junction, which relates to the symptom of fatigue. So, but the entire mechanism, the cytokines involved are still needs to be much elucidated, sir.
And now one last comment from Dr. Sagnik regarding management, and then we close this session.
So the problem with managing fatigue in patients with cirrhosis is that although we are aware of a large number of the mechanisms why it happens, there's not very effective pharmacotherapy that's available. So it's more of a combination of treating what is possible and then teaching the patient to cope with his abilities as well. So it's called the trace approach, where you first treat what are the treatable problems. So something like pruritus, which is very problematic in PBC, hypothyroidism, arthritis, or say anemia, which is all correctable and may help improve the condition. The second is amelioration, which is basically contributory factors, sleep disturbance, autonomic dysfunction, the patient's mental performance like depression or anxiety. And beyond that, it's to teach the patient to cope with his disability, like the ownership of the problem, asking him to arrange his activities in such a way to prevent exacerbation of fatigue. And lastly, it is to empathize. It is to understand that it is the problem that the patient has by virtue of his disease and not something that he's done, and to empathize with him rather than feeling sorry for him and encouraging him to get on along with his life. Okay. Pharmacological therapies are limited. These include ondansetron, S-adenosyl, methionine, and modafinil, although the evidence is limited for all of them.
So we will leave it at that. Any questions or comments from the audience, please? Okay, so I will thank my panelists, all the panelists, for active participations. Thank you very much. We close this session now.
I thank the moderator and the panelists for this insightful session. I wanted to make a note here that we'll be having our residents corner at 1 p.m. in Hall B. So I encourage all of my fellow colleagues to make the most of this. We'll welcome the chairpersons for the next session: Dr. Viral Patrawala, Dr. Devendra Singh, Dr. Lalit Shimpi, and Dr. Vikas Pandey. I request the chairpersons to please introduce the speakers.
So good afternoon, everyone, and we come to an important session of improving end-of-life care in terminal disease, something which sometimes may be a little neglected for us as clinicians. And we have Dr. Pankaj Puri, who is the Director of Gastroenterology at Fortis Escorts, New Delhi, to speak to us on that. Dr. Pankaj Puri, please.
Thank you, Chairman, sir. It's a pleasure to come to this wonderful hall, and I'll be speaking on improving end-of-life care in terminal liver diseases. Let's start with a case. RK, a 49-year-old male. He had ethanol-related cirrhosis and HCC. He's abstinent for 8 months. CTP-B, MELD 17. He had a 6 centimeter HCC, no vascular invasion, mild ascites, no encephalopathy. So life-threatening and potential curative options are feasible. My question is, how many clinicians will actually discuss palliative care? Let me be honest with myself. I will discuss it with the relatives, and it will be only an occasional patient where we will directly discuss this with the patient. I wonder in this hall, if I have a show of hands, how many people will actually discuss end-of-life care with the relatives? Anybody? So I see only a handful of 6 people raising hands. And that really is the scenario in our country. I think there is a time when our society has matured, when the basic need for liver care and transplant options have been met. It's a little bit like Maslow's hierarchy of needs for individuals. So this is something which is reaching the society's need of improving our care by looking at end-of-life care. So palliative care, our aim should be comfort and symptom control. It should be at the diagnosis of advanced liver disease, and it's not necessarily limited to the end-of-life phase as well. Here's another issue case. Here's a HCV-related patient. We go ahead and give DAs. They improve. They get off the transplant list. They no longer qualify for a transplant. But what they're doing is they're losing their priority for transplant, and they have a poor quality of life. They have complications of portal hypertension and hepatocellular carcinoma. It's something which we call a MELD purgatory, where they're not reaching heaven and they're still not good enough. They're not dying and they're not improving enough to go in and get a transplant as well. So patients with end-stage liver disease have a high symptom burden, poor quality of life, and a high mortality. The median survival in decompensated decreases to about 2 years. And the morbidity, the well-recognized one causes are bleed, ascites, encephalopathy, HRS, but they're less focused symptoms, as has just been discussed in the last session. You have muscle, you have pain, cramps, depression, and many other symptoms. When we're treating the patient, we also have caregiver distress to be account for. So end-of-life issues with patients with ESLD are often not discussed until it's too late, if at all they are discussed. We need to improve our end-of-life care, and the bereaved caregoers are less likely to rate end-of-life care as outstanding compared to other diseases. So we need to have patient participation in advanced care planning for end-of-life issues. There are many challenges when we try and achieve it. The disease has an unpredictable trajectory. You can have sudden life-threatening bleeds, encephalopathy, SBP, which can change things very dramatically. Transplant is an option which is available for many patients, and this potential care may transform their lives and put all discussions at a back burner. Patients can have hepatic encephalopathy, which can affect their decision-making ability. There is a social burden and a caregiver burden. And finally, the most important thing is it takes time. The hepatologist who already has a high, busy outpatient will find little time to spend on end-of-life care. These are sensitive discussions which need to be done in peace, and often a multidisciplinary care is required. So what constitutes end-of-life care? See, there is palliative care, there is advanced care planning, which I shall allude to a little later, and psychosocial support. All things would be required. These are overlapping terms. Palliative care, advanced care planning, hospice care, these are all overlapping. And hospice care is for a patient who has limited lifespan and doesn't desire any curative intervention, and the prognosis is less than 6 months. These are often done in nursing homes or often at home. Concurrent transplant and HCC care can be carried on while we do palliative care and advanced care planning, but is not considered in hospice care. We will continue to relieve the symptoms, give them tapping them if required for symptom control, and not just as a part of overall treatment, rather than in hospice care where terminal care is there, it will be aiming only at comfort. There are many domains of palliative care which will be physical. There have to be legal and ethical issues. We have to discuss with our patients to formulate the legal requirements, write their will. There will be involvement of the patient and the family. Spiritual has a role to play. It gives a comfort to many such patients. And there'll be barriers which will include, one of the major barriers which we find is because clinicians are reluctant to initiate palliative care discussions, as these are often misinterpreted as cessation of active treatment options. Another, we have a lack of palliative care specialists, and our healthcare professionals are inadequately trained to handle these issues. When a patient gets decompensated cirrhosis, our first goal should be to manage the complications, ascites, hepatic encephalopathy, consider them for liver transplantation, and at the same time start palliation of symptoms. When they are decompensated, we do advanced care planning, look at caregiver support, and look at the end of life support at the same time. Palliation includes many things, which would be treating the symptoms, which would be hepatic encephalopathy. We would avoid medicines which will worsen encephalopathy, give drugs which will improve encephalopathy. Psychosocial burden will include adding SSRIs, having support groups, caregiver support, and involve them in social care. Advanced care planning, they should include a living will, giving their desire of end of life care, and there should be a healthcare power of attorney. There should be control of pain, which would include pharmacological as well as non-pharmacological measures, control of ascites, and hospice referral if they are very advanced liver disease where the MELD is more than 21 and the child PU is more than 12, and we expect that the life expectancy is less than 6 months. So when should we discuss advanced care planning? So as I said, if the disease life expectancy is less than 6 months. Also, if there are other complications like ascites, variceal bleed, encephalopathy, frequent hospitalizations, severe sarcopenia, patient becomes bed-bound, has decreased functional status. But at the same time, it should not be left too late. Often these patients get hepatic encephalopathy, and the ACP discussion should be done early in the disease trajectory before they get encephalopathy. Advanced care planning has 2-3 roles. The first is to educate the patient and the caregivers about the disease process and the trajectory, allow them to express their goals and preferences about life-sustaining treatment. There should be prospective discussions as to what they really want in end-of-life care. They should appoint a substitute decision maker. We should document what are their end-of-life preferences. Do they want medical interventions? Do they want do not resuscitate options? This can also empower the caregivers. They can with comfort make decisions without having any guilt or stress on theirs. It decreases a lot of their caregiver stress and anxiety and improves the family's satisfaction with care. The various steps in advanced care planning is first thing is to see if the patient has encephalopathy. Can he make the decisions on his own? You should ask who all he would like to have along with him as part of the conversation. Look at the goals, explain the goals, take his permission. See that he understands everything which you're telling him. What the disease process is, what are his options. Give him all the prognostic information. Explore his preferences and values. Document these preferences and document who will be the surrogate decision maker. Once we've done this, with period of time, we should revisit this as things change, whether his options have changed. When we break the disease process to the patient, we should give them curative options which are available, like liver transplantation. Many patients, it may not be feasible, especially in India, where it's a living donor liver transplantation based programs, and very few cadaver programs are available. Funds, costing are also issues which are important. The second option is comfort care. Give them the best and the worst case scenarios and let them decide what their options of end of life care would be. When we do all this, we shouldn't forget the caregivers. There's factors which will increase the burden of caregivers for patients with liver disease will include encephalopathy. The relatives will get very disturbed when the patient is talking irrelevantly. Multiple hospitalizations, active alcohol abuse, additional costs, all these will increase the burden of the caregivers. We should look at the psychological distress. We should look what their financial positions are and when we give them options of treatment. Logistics are important things to look at. There's a lack of time, as I said, is one of the major barriers. We can have validated screening surveys which can be administered by ancillary staff to alert providers of symptoms requiring attention. Dedicated specialists in India are rare, and that is something which is a need of the hour. It should be a multidisciplinary approach where there's a role of healthcare team which should include not just the physicians but also the nurses, the social workers. The religion has an important role in calming influence in many of these patients. There needs to be a coordinated care. Family involvement and including the caregivers in decision making along with emotional and social support. They will need psychological support, not just the patients but also the caregivers. And as I said, spiritual care is one place where it calms many people. Palliative care and liver transplant can coexist together. There's a misconception that palliative care cannot be delivered concurrently with curative of life-prolonging therapy such as liver transplantation. When we advise palliative care, it's not just about giving up on the patients, and we need to incorporate palliative care program early in the disease process. Because even after we lift them for liver transplantation, about 1/5 of the patients will die or be removed from the transplant list annually due to the progression of the disease. And the spectrum of care should integrate early. And we should look at, if you look at the disease process, when the disease starts worsening, we look at curative and life prolonging care. We manage the symptoms. And as the disease progresses, we start discussing the end of life care options. And if the patient dies, the bereavement process to the caregivers also needs to be looked into. If we look at this chart, we'll have patients who have stable disease here, decompensation, they get transplant evaluation, get wait list management, and end of life. So the education should be early, and as the patient starts getting decompensated, we do advanced care planning. And caregiver support and bereavement are all different processes we need to be incorporated in the various life cycle of the patient. To conclude, clinicians caring for patients with liver transplantation should balance prolonging life through optimal disease-specific therapy so that we provide high care palliative care. And improving end-of-life care with terminal disease requires a comprehensive approach which will include palliative care, symptom management, advanced care planning, and psychosocial support. Multidisciplinary approach and family involvement is important. Talking of end-of-life care is not about giving up on the patient. Thank you.
Thanks, Dr. Pankaj. Please take your seat on the dais for the question answer at the end of the second lecture. May I now invite my friend Dr. Neeraj Saraf, and he'll be talking on another important topic, approach to recurrent fever in advanced cirrhosis. Neeraj.
Thank you, chairpersons. Thank you, Akash, for inviting me here. So the topic given to me was approach to recurrent fever and advanced cirrhosis, and honestly, I didn't know what to talk in this. So with Akash's permission, I have expanded the title a little bit to recurrent fever and prolonged and persistent intermittent fever as well. So in the next few minutes, I'll try and take you through this based on a few cases as well. So why is recurrent or prolonged intermittent fever important? What are the causes? So I have grouped these causes into 4. So there can be fever because of the liver disease itself. There can be a chronic infection or chronic diseases causing intermittent fever. Then infections in cirrhosis like SBP, pneumonia, UTIs, they can be recurrent. And then a lot of times we have drug-induced fever, which can be intermittent or recurrent. So I'll discuss the approach to these, and eventually, in an advanced cirrhosis, recurrent fever or persistent fever carries a lot of implications for liver transplantation because you can't transplant these patients with fever. And then I'll try and give an algorithm on how to approach these patients. So what are the implications of recurrent fever? Obviously, they need extensive workup, multiple admissions. It adds to the cost. It further decompensates the patient. It can cause ACLF, can lead to sepsis, morbidity, and mortality, and it delays or even sometimes prevents a patient from undergoing a liver transplantation. So before I go into the causes of such fever, I just wanted to discuss a few inflammatory and infection markers which I'll be talking of, and which are a little controversial, compared to the straightforward cultures or imaging. So one thing which, couple of things which we commonly use in clinical practice in cirrhotics are the CRP levels, the PCT. So CRP, is it really good in cirrhosis? So this is a position statement which was published almost a decade ago by EASL, in which they've talked that a cutoff of more than 10 has proven to be useful marker to predict the likelihood of clinically significant infections in patients with cirrhosis. And a cutoff of more than 24.7 has a very high ROC curve for predicting sepsis. But there is a caveat to that. Patients with cirrhosis may have a reduced CRP also, and up to 15% patients with cirrhosis actually have a low CRP. So similarly, procalcitonin, a cutoff of 0.49, the area under curve is highly predictive of infection and sepsis. But the caveat again is that you can have non-infective inflammatory conditions also causing a high PCT. Probably a combination of CRP and PCT may be more useful in such patients. So I'll just quickly go through a couple of cases. So this is a 42-year-old female who lives in Gurgaon, presented to us with 2 months history of jaundice and intermittent fever, and was managed outside conservatively with antibiotics. Before she came to us, she was diagnosed to have autoimmune-related hepatitis with chronic liver disease, and this was based on a transjugular liver biopsy and autoimmune markers. She had developed ascites and had needed a LVP and also had SBP. And when she came to us, she had recent episodes of hepatic encephalopathy, and there was no hepatorenal syndrome. So when she came to us, she had a bilirubin of 26, high liver enzymes, a very high CTP and MELD score, and we didn't think she was a candidate for steroids at this point, and we planned a liver transplant. Now, she continued to have fever, 100 to 101 degrees for the next couple of weeks. We did a routine, the panel for fever, the counts were slightly elevated, all cultures were negative, procal was slightly elevated. We obviously gave her broad spectrum antibiotics. The CT chest showed some small opacities which weren't considered significant. There was a portocaval lymph node, a little more than 10 mm in the para-aortic region, but to rule out if that was causing the fever, we did an FNA which was negative. Those were COVID times, so obviously COVID was also kept in the differential, and the RT-PCR was negative twice. So we didn't find any cause for fever. She was having fever for about 2 weeks, every 2-3 days, and we decided that the patient, we'll take up this patient for a liver transplant. And she had an uneventful course, and the fever subsided after liver transplant. So this, we probably thought the autoimmune hepatitis itself was causing the fever. And so there's a set of conditions in which you can have prolonged intermittent fever due to the liver disease itself. So autoimmune hepatitis is one such condition where you make the diagnosis on markers and biopsy, rule out other infective causes, and of course, the treatment is steroids, immunosuppression, and liver transplant in advanced disease. Primary sclerosing cholangitis is again, and I think probably if you ask me truly, which is, I would think this is the only condition causing recurrent fever in a cirrhotic patient. I mean, obviously you can have UTI 5 times and you can have SBP 5 times, but genuinely probably this is the only disease causing recurrent fever in cirrhotics is PSC, where you know that patients undergo recurrent cholangitis, have fever, and they're diagnosed by MRCP, ERCP. Antibiotics, biliary drainage is the treatment, and in advanced disease or recurrent cholangitis, they need to undergo a liver transplantation. HCC is another similar condition which sometimes we do see presenting with fever, in a prolonged fever with some intermittency, and the most common I think would be probably alcoholic hepatitis, where we do see fever a lot, and it's sometimes continuous, sometimes intermittent, and it's really difficult to differentiate it from infection in these patients because they are prone to infections as well. They're usually sick patients. So maybe a rapid sepsis PCR, a rapid sepsis test, procalcitonin, cultures, imaging help us in deciding whether this is fever because of alcoholic hepatitis or because of an infection. And again, this has implications in transplant because a lot of times you need to transplant these patients, and if they're having fever, you don't know whether to, it's difficult to rule out infection. This is another case, a 35-year-old male patient with compensated cirrhosis, presented with intermittent fever for 2 months. His blood cultures, Vidal, malaria, dengue, etc. were negative. He was compensated cirrhotic, X-ray was normal. He had hypotension, hyponatremia, hyperkalemia, so there were features of adrenal insufficiency. Cortisol levels were normal. A CT scan showed bilateral adrenal enlargement, and we did a EUS, and there was a 3.2 centimeter left adrenal heteroic appearance and a maintained outline. There was a mass, and a EUS guided FNA showed numerous thin-walled round yeast forms against a necrotic background, and they were positive for the Gomori methamphetamine silver stain, and the morphology was consistent with histoplasma. So this is what this patient had, histoplasma. And what I want to highlight here is that if you're having in a cirrhotic continuous fever or an intermittent prolonged fever, and you have lymph nodes or an abscess or a mass, tissue diagnosis is a must. We should not, sometimes we're carried away. A lot of times we see physicians prescribing empirical ATT, and like you can see in this patient, it turned out to be histoplasma. So another common group of prolonged intermittent fever are chronic infections and diseases, and they're not uncommon cause, and causes are tuberculosis, fungal infections, lymphoma, malignancy, sarcoid, and other autoimmune diseases. Approach, well, I think the imaging is extremely important, so we need to do a CT, chest, whole abdomen, and maybe a whole body PET CT. And like I said, a tissue diagnosis is extremely important to find out the cause of fever in these patients. Again, in diseases like tuberculosis, you'll have, ascitic or a pleural fluid needs to be assessed using the TLC, DLC, ADA, cultures, gene expert, and I'll talk a little about that. Autoimmune panels, tumor markers must be done. A lot of times in patients suspected lymphoma, you need a peripheral smear, a bone marrow, and we must rule out other causes of infection. So I'll take half a minute to talk about tuberculosis, approach to fever in a patient we're suspecting tuberculosis. So when, the SARG is the commonest test we do to find out the cause of ascites in a cirrhotic patient. And we know that low SARG has a very high sensitivity in non-cirrhotic patients, but when you have portal hypertension, the sensitivity drops significantly to 28 to 88%, and it's mostly 30 to 40%. ADA is another marker, and if it's more than 30, then it has high sensitivity and specificity, but we know that it can be falsely low in cirrhotic patients as well. Other tests are Gene Expert, which is a PCR test, and which has been shown to have a sensitivity of 64 and specificity of 97%. IGRA, the interferon gamma release assays, also have some value in diagnosing TB, and this meta-analysis of 12 studies showed a sensitivity and specificity of 90 and 78%. So these are some tests which can help us in diagnosing tuberculosis in a patient of a prolonged intermittent fever in liver cirrhosis. Another group of patients, and I'll go through this case, a 37-year-old male, diabetes, obese, hypertension, came to us with jaundice ranging between 20 to 30 milligrams. He had hepatic encephalopathy, ascites requiring LVP, coagulopathy, and we diagnosed him to have acute and chronic liver failure. He was admitted for more than a month. Transplant was being planned, but they didn't have a donor initially. He underwent multiple therapeutic plasma exchange sessions, and he was on antibiotics initially, ceftriaxone, sulbactam, and teicoplanin. We did find a donor, and he was evaluated for transplant, but he continued to have fever. Again, this was a point which made us delay the transplant, and he had more than 100 Fahrenheit fever, and this would happen 3 to 4 times a week. And after all investigations, cultures, imaging, everything, we could not find a cause for fever, and this was delaying his transplant. And as you know, in a patient with ACLF, that could be fatal. So this patient had, again, a normal procalp, CRP. The imagings were essentially normal. No definite cause for fever was found. We increased the antibiotics to meropenem and tetracycline, and again the fever continued. We sought an ID referral, and so this is a screenshot from. So we do a MDT in every single liver transplant patient, and where we discuss the problems. So his problems was the fever, and ID suggested that this is probably drug fever, and we should stop all antibiotics. We weren't brave enough to stop all antibiotics, so we de-escalated them. The fever subsided on day 3, it didn't go away, and this patient underwent a liver transplant, thinking that this is a drug fever and not an infection. He did have a stormy post-op course. He had renal dysfunction, but there was no sepsis, and he was discharged after a month. Let's skip this. So drug fever is also something which we must keep in mind, and most of the antibiotics actually can cause drug fever, and I think this is something which we must keep in mind when we're talking of intermittent or persistent fever in patients with advanced cirrhosis. And last but not the least, the recurrent fever due to infections in cirrhosis. So obviously you can have SBP, skin and soft tissue infections, recurrent UTIs, pneumonia, where you probably diagnosed by CT, bronchoscopy, and cultures, IV line related infections, and GI infections. And again, I'll not go into details of the management or approach to SBP and cellulitis, etc. I think we are well versed with that, with what the treatment is for SBP, pneumonia, fungemia, etc. Again, sometimes the recurrent fevers can be multi-drug resistant, and the most implicated in these cirrhotic patients are gram-negative bacilli and E. coli, Klebsiella pneumonia, and Pseudomonas, and I think this is something which we need to keep in mind. Invasive candida is again a cause of recurrent fever in a lot of patients with cirrhosis, because and mainly because of recurrent admissions, recurrent ICU admissions, and they're more prone to candida infections. So recurrent or prolonged intermittent fever, again, like I said, has implications in liver transplant. You need to find the cause of fever. Active infection, the results of transplants are poor. It delays the infection, it causes mortality on the waiting list. And we must remember, like I highlighted in one of the cases, every fever is not infection. And this is my last slide. So if we have an advanced cirrhotic patient with recurrent fever or prolonged intermittent fever, we should uh, probably do routine investigations first, like a good clinical exam, CBC, peripheral smear, procalcitonin, CRP, cultures, imaging. If you don't get an answer, then maybe a PET scan. Sometimes, like I said, tissue is important if you find some lymph nodes or a mass, and a lot of times a bone marrow is needed. And these are the 4 categories which we should keep in mind. Liver disease related fever, which are autoimmune, PSC, alcoholic hepatitis, and HCC. Fever because of complications of cirrhosis like pneumonia, SBP, cellulitis, etc. Drug fever, which is usually a diagnosis of exclusion. And then fever because of chronic infections and diseases like TB, sarcoid, lymphoma. And like I said, we need a tissue and culture to really prove them. Thank you.
Thanks, Neeraj. Please take your seat on the dais for questions. Now, both the lectures are open for questions and discussions.
So maybe we'll have one question here from the dais. So this is a question to Dr. Pankaj Puri. So unlike advanced malignancies where you have more predictable course of downhill of the patient, and then you can talk about end of life care to the relatives and the patients. A lot of times our patients with chronic liver disease or cirrhosis have a very unpredictable and sudden deterioration. You know, they'll come with they're doing well, came with a sudden GI bleed or NSAF or sepsis, landed up in ICU and then they don't make it. So we also have a lot of patients who are apparently doing quite well and then suddenly decompensate. So do you think there's a limitation in discussing end-of-life treatment in this scenario because it's a little different from what you get in palliative malignancy, hospice kind of scenario?
So I agree with you. That's one of the challenges of discussion of end-of-life care in people with liver disease. But I think the discussion on disease process and explaining and giving knowledge to the patient starts when they're well compensated. End-of-life care discussion should start at the first sign of decompensation, and not wait till they are really advanced liver disease. If we do that, then we are missing the bus. At the first sign of decompensation, we should have end-of-life care. And the discussions about the disease process, the unpredictability, the fact that many of them will decompensate over the coming year, all needs to be discussed with them when they are well compensated.
Dr. Puri, there is a very thin line that divides between offer of palliation and writing of the patient. Many times, your offer of palliation may actually be misconstrued by the patient's relatives as he's writing off the patient. In that scenario, many patients, they actually end up receiving complementary and alternative medicines, and they almost leave the standard medical treatment. That may be counterproductive at times, I guess.
So the first thing is that we as clinicians should be confident and understand that giving and offering palliative care is not writing off the patient. Only once we are convinced as a community will we be able to express it well to our patients. You can offer palliative care and simultaneously work up the patient for liver transplantation. Both things can run concurrently. And once we can explain to the patients that we are giving them care, but this care can not always be predictable. They may not even reach a liver transplantation and they should be ready for the alternatives. But giving them the alternatives doesn't mean that we are withdrawing care. Once we understand this, we'll be able to express it better. Most clinicians will not discuss this with the patients. We will often discuss it with the relatives. But the person who has to make the decision, which is the patient, is often never included in this discussion.
Yeah, question from their side.
Yeah, Dr. Neeraj, you discussed the fever in a patient with the cirrhosis very well. In the first case, probably it was AIH which was causing the fever. But where did we go wrong? Because in that patient, bilirubin was quite high, ascites was there. So the immunosuppression this patient received, but the fever did not disappear.
So no, this patient did not receive any immunosuppression.
Why? Because the diagnosis was clear in this patient.
Yes, sir, but with the hepatic encephalopathy, history of SBP, ascites, a MELD of 28, I don't think immunosuppression is indicated in these patients. They will get worse if you give them steroids. So I think such patients should directly go for transplant.
So this is one way that these patients should directly undergo the transplant. The another way is this probably was having a severe sepsis. So you control sepsis, and once the sepsis is controlled, put them on low dose immunosuppression, and many of these patients will do better.
No, I agree, but this patient was getting antibiotics and there was no improvement. So there was no element of sepsis which was reversible. So, I mean, the point I wanted to highlight here was that autoimmune can cause fever itself, and sometimes you can't, and obviously this patient was not a candidate for steroids or any immunosuppression.
Another thing which I want to highlight is the many patients with the ACLF, and clearly the history of alcohol intake is there, and they are deteriorating, and they are planned for the liver transplant. This happened with one of our patients who was referred to your center, and in that we did the anti-HCV testing twice and it was negative. And when this was done again just before the transplant, the HCV RNA was quite high. And in that patient, the transplant was deferred, and we treated with the DAs, and that patient is fit and fine. We sent this patient for the liver transplant, and this patient is still maybe another 6 months back, and this patient is fit and fine. There is hardly any problem with this patient. So we should also think of the active HCV infection, although the anti-HCV was negative in this.
You are requested to keep the question short and crisp.
Professor Rai, I think this could be the last question for the session.
It is excellent talk. I just
thing.
wanted to know about many of the patients of cirrhosis have evening rise of temperature, and that is so recurrent that reaches up to 101. All tests are negative. What would be your approach to that patient? Because they are much worried about it.
So again, I think we need to look at the definition of fever also. So a lot of times, by definition, see, a lot of patients complain of evening rise, and that is a very subjective thing. They have not actually measured the temperatures. And a lot of times temperatures are measured, and if you have a temperature of 99, by definition, it's probably not a fever. So I think obviously you need to work them up. But if everything is negative, then I think you just assume that it's normal.
The last question to Dr. Neeraj. You receive a lot of patients of ACLF, probably in sepsis. So they have already received antibiotics. What is your take on adding antifungal? When do you add it? Is there any marker for it, or directly day one of admission you consider adding an antifungal to these patients?
Yeah, so I mean, I don't think there's a very clear-cut answer to this, but yes, if patient, I don't think we would probably add it on day one. But yes, if a patient has come to us from a different hospital, has been in an ICU, then we would keep a very low threshold. And if there is markers of infection are present, fever or high TLC or organ dysfunction, then I'd keep a very low threshold for adding an antifungal in these patients.
Thanks. We close the session. Thank you.
Yeah, I would like to thank the speakers and the chairpersons.